Today, we're diving into one of the most high-stakes tools in all of modern medicine, thrombolytic agents. You've probably heard them called clot busters, and honestly, they can literally be the difference between life and death. Just think about that for a second. A silent, hidden threat, just counting down inside your own body, ready to cause catastrophic damage at any moment. Well, for millions of people every single year, that ticking time bomb is terrifyingly real. It's a blood clot, a dangerous blockage in the superhighways of our circulatory system. And that's really where we have to start, by understanding this enemy within. Because, a clot isn't just some simple clog in a pipe. It's a full-blown, life-threatening emergency. So, the official medical term is a thromboembolic event. This happens when a clot gets loosed, travels through your bloodstream, and then gets stuck. It cuts off blood flow, leading to something called malperfusion, which is basically a fancy way of saying a vital organ is being starved of the blood and oxygen it desperately needs. If that organ is your heart, that's a heart attack. If it's your brain, it's a stroke. Your lungs, a pulmonary embolism. The stakes, well, they just couldn't be any higher. So how in the world do you fight an enemy like this? Well, the answer, it turns out, wasn't invented in a lab. It was discovered by decoding a secret weapon that was already hidden inside our own bodies. It's incredible, really. Our body actually has its own built-in clot-busting process. See, when a clot forms, it's held together by this web of a substance called fibrin. Now, floating around in our blood, we have this inactive agent called plasminogen. It's just waiting. When we need it, a regulator called TPA basically flips a switch. That activates plasminogen, turning it into plasmin, and plasmin is the hero here. It's the active agent that chews up that fibrin mesh and dissolves the clot. This whole natural process became the blueprint for the drugs we use today. And this timeline, wow, it just shows what an incredible scientific journey this was. It all started with a total accident back in 1933 with the discovery of streptokinase. Then it took more than 20 years just to isolate our body's own TPA. And then another 30 years to figure out how to bioengineer it into a drug, alteplase, which finally got FDA approval in '87. That's over half a century of work, all to weaponize our own biology against itself. All right, so let's talk about those early drugs, the first generation of clotbusters. I mean, they were absolutely revolutionary, but they were more like blunt instruments than surgical tools. So the two trailblazers were streptokinase, which, get this, was derived from the same bacteria that causes strep throat, and urokinase, which was first isolated from human urine. Wild, right? But they both shared this one critical flaw. They weren't specific. They just turned on the clot-busting process everywhere in the body, not just at the site of the dangerous clot. It was like a system-wide flood. And streptokinase had another huge problem. Because it was a bacterial protein, your body's immune system could see it as a foreign invader. That means you could develop antibodies against it, making a second dose, say a year later, completely useless. Your body would just neutralize it. This flaw was a massive driver for innovation. We needed a smarter solution. And that brings us to the next generation of these drugs. This was the quest to build a smarter bomb, one that could actually tell the difference between a dangerous clot and the rest of your body. This chart just lays out the evolution perfectly. The first generation, like streptokinase, had really low specificity. It was a system-wide effect, a total grenade. But the newer generation, like alteplase, highly specific. It's way more targeted to the fibrin in the clot itself. Its mechanism directly mimics our body's own TPA, which is a massive leap forward. And its origin? Not bacteria, but recombinant DNA technology. It's a precision-guided missile. And that real game changer is alteplase, also known as rTPA. But creating a bioengineered copy of our body's natural TPA, medicine finally had a much more precise weapon. It's designed to be more active right at the site of the clot, which makes it a much more targeted and safer therapy. But listen, the drug itself is only half the story. How you deliver that payload is just as important. Are you going to flood the whole system, or are you going to go for a precision strike? So you've basically got two main approaches. You can give the drug systemically, just through a standard IV in the arm. We call that the flood. It requires a really high dose and, you guessed it, carries a higher risk of causing bleeding somewhere else in the body. The alternative is catheter-directed therapy, the precision strike. Here, a doctor threads a tiny catheter right up to the clot and delivers a much lower, super localized dose. This dramatically reduces that systemic risk. And all of this leads to the real climax of our story, the high-stakes choice that every single doctor faces. It is a true life-or-death balancing act. So what's the single most dreaded complication of using these drugs? It's bleeding in the brain. For patients getting thrombolysis for an acute ischemic stroke, that's a stroke caused by a clot, the risk of causing a brain bleed is 6.4%. Now, I know that might not sound like a huge number, but when the consequence is a catastrophic brain hemorrhage, it's a terrifyingly high number. Yeah, the source material puts it about as bluntly as you can. This quote gets right to the heart of the matter. You are using an incredibly powerful tool designed to dissolve clots, and that power comes with an inherent, unavoidable risk of causing a bleed. So, this is the crucial part. There are absolute red lines, situations where the risk is just too high. If a patient has active internal bleeding, or they just had major surgery or a recent trauma, you simply cannot use these drugs. The danger of causing a catastrophic bleed completely outweighs the potential benefit of dissolving the clot. And this right here is the dilemma in a single sentence. You have that ticking time bomb, the clot, that you absolutely need to diffuse. But the very tool you use to diffuse it could, itself, cause an explosion somewhere else in the body. Which leaves us with the one fundamental question that defines these incredible, life-saving therapies. When a doctor pushes that drug, are they starting a cure? Or are they starting a catastrophic complication? It's a question that gets answered minute by minute in the highest stakes moments in medicine.